So on our little schedule, it said pyloric stenosis, which of course 30 minutes is way too long to do that. So we crammed a couple other things in there. And so we're going to have a lecture this week, next week, and the following week on ped surgery. I'm just going to throw as many little topics in there as we can, mainly with keywords. This isn't going to be the most in-depth review of this stuff because you don't need that. You only have maybe 6 or 7 questions on the whole test of ped surgery. But unfortunately, 5 or 6 questions, if you don't get them right, really affects your grade with the way they do that. So we'll try to cover the bases and kind of go over stuff. So we'll start off with pyloric stenosis. You guys are pretty familiar with this. You'll see this a lot in our service. Seems like we have 2 or 3 of these every month. They don't really know what causes pyloric stenosis. They have some theories about it. Basically, they all seem to involve nitric oxide synthase being abnormally regulated, and if you don't have that, the muscle doesn't relax and it seems to hypertrophy. As we see in other diseases and seems to be popular in tests, tyrosine kinase receptors seem to be involved in a lot of things, and this one particularly has c-KIT as the tyrosine kinase that is involved with it. There's other neuropeptides. You may see something called substance P on your test. That's been involved in it as well. But basically, they all revolve around progressive gastric outlet obstruction. And in adults, when you have gastric outlet obstruction, you have a very particular type of metabolic or electrolyte derangements, and we'll go over that in a minute. And it's just pretty much the same thing. It's almost like a little case study on how that works with pyloric stenosis. So 1 in 300 babies gets it, so we see it pretty commonly, but you'll see reflux about 100 times more often if you're a pediatrician than this, because 1 in 3 babies have some version of reflux. So it gets misrepresented that way. More common in Caucasian babies. There is a familial rate. If mom or dad has pyloric stenosis, you do have an increased risk of their children having it. It's more common in males. You hear more common in the firstborn male. Babies that are exposed to pertussis in the household and then get erythromycin prophylaxis seem to have a higher risk of this. So you might see on the test when they might say that a sibling had whooping cough, and basically, now the kid is presenting this way, and that's one of the associations with it. Keywords to remember. I don't know if y'all have seen Monty Python. If you're a Monty Python thing, you'll remember the wafer thin mint. But basically, pyloric stenosis, projectile vomiting, right? So it's non-bilious, okay? That's key. If it's bilious vomiting, it's not pyloric stenosis. The pylorus blocks stuff going either direction, okay? So the bile can't get back in the stomach. So if it's bilious, it's not pyloric stenosis. You should be thinking about more severe things. It's projectile, usually later in the course. It's progressive. The family will say, okay, it's been getting worse over the period of days or a week. And after the kid eats, they're not satisfied, so they'll vomit after they eat, and then they keep crying as if nothing got absorbed, because it didn't. And then, of course, the olive test, or the sign that you can feel sometimes. So there's another mnemonic. So here's the olive. I want to give you these pictures just to kind of burn it in your brain. So you have this baby. Here's the pyloric stenosis. They can't go this way, so it defaults to going this way. You have this projectile vomit. It's usually curdled looking and very pasty. It's not green, not bilious. And there's the devil baby thing from the internet or from YouTube. And then the palpable olive. So if you remember that, you remember a lot of the things, okay? So differential diagnosis. So things you have to worry about, or it may present as, or on the test might be, other possibilities. Reflux, pylorospasm, overfeeding. Usually they'll give you a number like, oh, mom's giving the baby 5 or 6 ounces, which is too much for a newborn baby. Increased intracranial pressure, that is a cause of vomiting in any child. And then more rare things, pyloric atresia, antral web, duplications. And then metabolic issues cause children to vomit. But the projectile nature of it and the palpable olive, those things are not seen as often with anything else. So in the old days, we could just palpate the olive, and if the history was good, that was all you needed to go to the operating room. And it's still true. The problem is that's about a 15-minute ordeal, and the kid's crying, and everyone's nervous about it. And so they pretty much now ultrasound is what's going to be on your test, but you can diagnose it with physical exam alone. So ultrasound is the thing that you want to do. If you're not sure, or if you think, man, they probably have reflux, or maybe they have some other issue, I don't really think it's pyloric stenosis, then I tell people to get an upper GI, because that way, if you rule out pyloric stenosis, you also have an upper GI to also look for things like malrotation or a web or some type of atresia, things like that. But on your test, ultrasound will be the answer. So on ultrasound, this is the pyloric muscle here. It's not the best ultrasound, I apologize. I tried to take these out of your SCORE textbook, so at least it would look familiar if you actually studied for it. Just kidding. So basically, this is the pyloric muscle wall here. This is the thickness, and this is the length. Usually the length is about 3 times the thickness. So 3.5, these numbers change based on which textbook you read, but on a test they'll give you something way above that, like 5, 5 or 5.5. And a channel length, they may give you 18, 19, or 20. So if you remember about 3.5 or 4 and 14, like 4 and 14, somewhere in that range, that'll be good to get you through everything you need. Also, they may say whether or not there's fluid peristalsing through this area. They may say there's no peristalsis through the pylorus. That'll give it away. Now, in real life, if you're in a hospital where your sonographer or your radiologist is not real good at doing these, then get an upper GI, because they commonly, if they just tilt this thing the wrong way or don't get it aligned right, they'll throw the measurements off, and then you'll refer your patient out for reflux, which we see pretty commonly. Upper GI, still a great test. Never in my mind a wrong answer. It's just ultrasound's easier to get if your facility is good at doing it. So this is the string sign that you may see on the test. So normally the pylorus would be about from here to here, okay? And then imagine this is a thickened muscle, the edges of it here, and it has shoulders. So you'll see something that may look like shoulders here and here. So if you see those things, or you see the string sign, that's pyloric stenosis on your test. So this is always associated with it, and they always talk about it, but you only see this in about half the cases. So when babies vomit, they lose hydrochloric acid. When they lose hydrochloric acid, they lose hydrogen ions and become alkalotic, and they lose chloride. Okay? Well, if you don't have chloride, then your kidneys have a problem secreting or getting rid of bicarb. So then your alkalosis gets even worse, because you hold on to the bicarb when your kidneys are trying to excrete it in order to correct acidosis. When you get hypovolemic, a little bit later on, you make more aldosterone. If you make more aldosterone, you'll retain sodium to expand the volume, okay, and fix the volume deficit. But you'll have to excrete the potassium with hydrogen, the hydrogen-potassium pump. And so basically this is where you get the paradoxical aciduria, and then the volume gets expanded from the aldosterone. So when you have all this, the main problem is alkalosis. And if you have alkalosis, how does your brain respond? It inhibits your respiratory drive to increase your CO2. Increase your CO2, you have more acid, quote unquote, in your blood to try to correct the alkalosis. Well, the problem is the most common cause of cardiorespiratory arrest or cardiac arrest is actually hypoventilation in children. So they get apneic. And so we don't do this surgery unless the CO2 has been corrected, because there's no reason to do a non-emergent surgery and cause a kid to become apneic. So just in preparation of surgery, unlike other types of obstruction, let's say like malrotation or let's say a post-op obstruction, this one's not an emergency. So you can wait several days to do this. You basically have to correct the electrolytes. You don't need an NG tube in this children. Actually, most people think it makes it worse. Once you stop feeding them, they don't vomit much. They may have a little bit of stomach secretions and stuff that they vomit, but it doesn't warrant an NG tube generally. Now, if you do an upper GI, sometimes they'll leave an NG tube down, and that's fine. You can suck out that contrast just so it's not, it's not a mess when you put them asleep. But generally, you don't need an NG tube. You leave them NPO. There's no reason to feed someone who's obstructed. The fluid that you give D5 half normal saline, and then you do put potassium in it. We always say until we know that the urine output's going that we don't give potassium, and that's in the fluids, and that's a safe thing, but you always pretty much end up giving it eventually. So, and most of these kids are not so dehydrated that they don't have renal output. But you have to give it at an increased rate because you have a deficit of chloride, so you have to replace that. So fluid resuscitation, so your endpoints are to get your chloride over 100 and your CO2 less than 30. So if a kid presents and their chloride's over 100 and their CO2 is less than 30, you can repair it. You can go ahead and do it whenever it works for the OR schedule and for you. Anesthesia concerns, again, alkalosis and immature respiratory drive equals apnea bradycardia, bad. So if they are alkalotic, they may not come off the ventilator because they don't have that natural drive to start breathing again. And you want to make sure that you empty the stomach very, very well before you intubate them. So the anesthesiologist is going to put a red rubber catheter or something like that down, suction them out real vigorously, because aspiration is one of the complications you may see on your test. You avoid narcotics because that with recent alkalosis, for some reason, they just want to stay asleep forever. They don't really need it. They need a little local anesthetic and some Tylenol. So the procedure is, no matter which way you do it, it's always a Ramstead pylorotomy. It just depends on how you get to it, and I'll show you a picture. The board answer, I'm talking about your oral board answer, is an open incision right upper quadrant. Unless you are good at unless you've done a bunch of them through the transumbilical route or a laparoscopic route, which you're not going to be able to do within a couple months on service here or there. Don't go saying, oh, I do it with the laparoscope. You can tell them that most people would do it with the laparoscope, and then your thing is, but since I'm not doing that or I'm not in general practice, if I had to do that procedure, I would just do a simple right upper quadrant transverse incision. It's still acceptable. There's no problem with it. And how you do that, you make a little incision right here. You palpate the olive, and it usually ends up being right up here. You make a little incision about this big, and you take some Babcock forceps. You pull the stomach up first, find the stomach, and then you follow it this way to pull the pyloric olive out, and you plop it out of the wound. And then what you do is you actually kind of pinch it to feel either end of it, and you don't go exactly to the end of your fingers with it because the edges roll over, okay? So if you go all the way to the end, you'll go too far. So you go most of the way. And then with the 15 blade, you just want to go through the serosa. Then you can take the back of your scalpel, it's perfectly shaped, and put it in there. And you kind of wiggle it through the soft muscle till it goes to the submucosa. And then you turn it 90 degrees, and you're basically making just a little spot to then put in I don't have a picture of it, but then put in what are called Benson spreaders, which most hospitals will have. If they don't, you can take a hemostat upside down or a right angle upside down and put it in there and spread those muscle fibers. And you guys have probably seen on service that have rotated us do a pylorotomy and see the fibers go. Then you will get a pair of DeBakey's. You'll grab here, and you should be able to move those edges separate of each other. If when you're moving one side, it's really rocking and torquing the other side, you need to make the myotomy a little bit longer, more than likely. So that's kind of a cheap test for that. Complications, quoted about 2%. If you cut too deep or go too far, you have perforation. On your board exam, the answer there is to close the perforation with absorbable sutures and then turn the pylorus, rotate it, and put the myotomy somewhere else. Okay? If you have an incomplete myotomy, you cut too little, then you may have vomiting 4 or 5 days, continuously. Then you go back and pretty much, you usually just re-explore these kids because the upper GI won't look abnormal. Yes, sir?
On the score reading, it was seeming the way it read to me was saying that for the perforation, you just repair the
you can primarily
mucosal defect and then just basically treat it like a
patch.
ulcer. Yeah,
you can do that too. Yeah, that's perfectly fine.
Just in here, more for the oral boards.
Yeah.
What Dr.
Yeah,
Boykin
well,
said.
either way, just make sure whenever you do something on the oral boards that you know that it's not crazy and it's something you can do. But the main thing is that if you do have that, you have to do something about it, but the hard thing is it's easy to miss that.
But Boykin, do you if you repair it, do you insufflate with methylene blue to see any leak?
No, I mean,
Repair it primarily, and
just like you normally would. I mean, I don't test anything on there. And then when you do this procedure, you usually have them put air in the stomach and blow the stomach up. I mean, I'm saying just a normal repair and see if there's any bubbling or anything. That's a good test. And you can kind of push on the distal duodenum or just distal to the pylorus and then kind of fill the stomach with air for the anesthesiologist, and they can blow it up and then see if there's any bile staining or leak or anything like that. Let's see. Okay, so again, we'll finish this up. Projectile, progressive, postprandial, non-bilious. Then you'll see this, this is only 50% of the time, hypochloremic, hypokalemic, metabolic alkalosis. Just do a simple Ramstead pylorotomy. It's not emergent, so fix the chloride, get it over 100 and the CO2 less than 30. And ultrasound is the study of choice, typically. All right, let's talk about duodenal atresia. Okay, so duodenal atresia. So it's not all that common. And pretty much all these like cool things like TE fistula, duodenal atresia, blah, 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 the incidence always seems to be about 1 in 4,000 to 6,000. Not that they normally tell you that on the test, but if you ever need to know, it always seems to be like that. So it's a failure of recanalization, might be a word you hear, of the duodenum or incomplete rotation of the ventral bud of the pancreas that creates annular, that's what creates annular pancreas. Either way, they both cause obstruction. When the pancreas is developing as Dr. McDonald used to call the pancreatic enlage, it was an awesome word when he could say it. There's two buds of it, ventral and dorsal, and they spin around an axis. When it spins around that axis, which is the duodenum, or becomes the duodenum, if it doesn't separate when it does, it makes a ring around it, and that's annular pancreas. The thing to remember with duodenal atresia, Down syndrome. So those are associated pretty strongly, okay? And about half of them have some other abnormality. So types of atresia. The book, says that this web type configuration is number 1, and that's, I guess technically that's true, but it always looks a little bit like this. There's always a little bit of a gap. So I'm not sure exactly if that was a kind of a typo, but basically when you go to repair it, there's always a little bit of a gap. But I think what they're trying to show here is a longer gap, like a really long gap, but it's not really painted. Drawn very well. And then this fibrous cord, you don't see that very often. This is the most common, type A. Then you'll also hear about a thing called a duodenal web, and a duodenal web can act just like an atresia. Now, this is different from a windsock deformity. A windsock deformity, the duodenum may look completely normal on the outside, but on upper GI, you'll see something that looks kind of like a funnel. Okay? You may even explore this kid thinking they have malrotation. You go in there's no malrotation. The duodenum looks normal. They probably have a windsock deformity, and that's kind of a weird deal. You have to make a little incision in the duodenum and then run a Foley catheter up, inflate it, and pull it down to actually find it. And then the treatment of that is just to resect the web, except where the ampulla is. You leave that part alone. Again, that should not be on your test. Annular pancreas works the same way. It basically just chokes off the duodenum. So presentation, most of these will be seen on prenatal ultrasound, and they may show you on the test like a double barrel looking, double bubble looking thing. That's duodenal atresia, okay? After birth, you can see a double bubble. I'm sorry, this doesn't project very well. The larger bubble is the stomach. The other bubble is the duodenum, but it's huge, and that's duodenal atresia. You don't see malrotation present with the double bubble very often at all, unless it was in utero and it obstructed the duodenum. So just on test-wise, double bubble, duodenal atresia. After birth, upper GI, just a better view, the same thing. The key to this is when you see an upper GI and they say the kid's vomiting bile, if you have a big bulbous duodenum and it's smooth and rounded, that's usually not malrotation. Malrotation, the duodenum is usually not so big, and it's kind of either a corkscrew or a beak. So duodenal obstruction causes bilious emesis, and things that cause bilious emesis that you need to remember: duodenal atresia, annular pancreas, malrotation, some type of high atresia, jejunal atresia. Later on, you can have, within a day or two of life, you can have things like ileoatresia, Hirschsprung's, sepsis, things like that can cause it too. But traditionally, duodenal atresia and malrotation. So the surgical procedure that we do is usually a kind of a diamond anastomosis, where you have this area, this proximal dilated duodenum. You make a transverse incision, and then this distal, very small area, you make kind of a longitudinal incision. And then you start off by connecting the midpoint right here to the apex of this part here, which is right there. Put these two together, and then you complete your back wall. And as every anastomosis, it seems like you do like 50 stitches in the back wall, and you go to the proximal, the anterior part, and it's like ding, 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 and you're done. But it's the same thing here. And this is a really sweet case. This is one of our favorite cases because it's just elegant and it works. So remember, for duodenal atresia, double bubble on imaging. You can see it on an ultrasound prenatally. Bilious vomiting like malrotation, so sometimes you have to figure those out. Again, the appearance on the upper GI, if you need to do an upper GI, we'll show you. There's a high association with other abnormalities, and Down syndrome is very common. So when they see this, they will usually do an amniocentesis. So if you get a board question that says, a family comes in, they have a prenatal ultrasound, there's an abnormal finding, an amniocentesis is done, and it's abnormal, then there's a good chance you're dealing with duodenal atresia. Okay. All right. So TE fistula and esophageal atresia. So again, incidence about 1 in 3,500. Everything's around that, that kind of rarity. TEF stands for tracheoesophageal fistula, and EA is esophageal atresia. It's rare to have just esophageal atresia, so you usually hear these together. So TEF, EA, all the little acronyms, but basically, when people talk about TE fistulas, they usually mean a TE fistula with an esophageal atresia. So they're different types, okay? But the ones you want to remember is type C and type E. Okay, type C is the most common one, and it basically is the one you traditionally think of, and that's the one that is usually on your test. And what that is a blind ending pouch, proximally, and then a distal fistula. So when these kids breathe, air goes down into their lungs, and then some of it will go down in their stomach. But when they distend their stomach, some of the acid goes back up. So these kids are micro-aspirating, and they're filling their stomach with air. So they can get a compartment syndrome just with breathing and crying. And that's why you avoid positive pressure in these kids. And that may be on your test as well, and we'll go over that. But when you put an NG tube down here, it's going to stop right here. This is about 10 centimeters to 12 centimeters in on an average size baby with the TE fistula. So when you put the NG tube down, you'll see it curl up on that x-ray, and that's TE fistula. Okay? But the problem is not that the secretions are pooling up right here. The problem is that this connection here lets air go into the abdomen, which can cause compartment syndrome, and it lets acid go into the lungs, which can cause aspiration. The other type is the H type, is completely different and usually presents differently. The H type is, there basically is no esophageal atresia. There's just a fistula. The difference is these present later. These kids will have lots of aspiration pneumonias. They may present days, weeks, months, years even later. They're having recurring problems. They'll eat and then they'll choke, or they'll start coughing after they feed. And you put an NG tube down these kids at birth, and it's normal. It goes all the way down. They're like, oh, they don't have a TE fistula. If they have those recurring episodes, or what we call dying spells, then what the treatment, the diagnosis is made by doing a bronchoscopy. You can easily see this right here from the trachea side, but you can't see it very easily from here. Okay, and so the repair of this, unlike the others, which is through a thoracotomy, this one's through a collar incision up here, and it's actually all you have to do is go in there and ligate these, and then put a little tissue between to keep the fistula from reforming. So remember, type C is most common. Type E is the H type. These other ones, you probably won't see those on your boards, and if you do, it's unfair because they're not common and they're more difficult to deal with. So type C, again, blind ending pouch, distal fistula. Keywords for this one on the test: inability to pass NG tube beyond 10 to 15 centimeters, intolerance of feedings immediately after birth, unlike the other one where you would be able to eat and maybe choke. Mother had polyhydramnios. That fluid has to be absorbed to be recycled, and if it's not, then they make too much fluid, okay? Vertebral abnormalities, so there's syndromes associated with these TE fistulas, and so they may give you other things. Because they love to tell you, oh, this kid has blank, and then all of a sudden they skip to something else, and they don't, they assume that oh, this kid has a TE fistula, and then they ask you, what other abnormalities may you have? So vertebral abnormalities, radial abnormality, excessive drooling and choking with feeds is another thing that they say. H type, presentation is delayed, choking spells, feeding intolerance, aspiration, and the NG tube will pass normally. So that's the difference. So you have associations, you have Vacral, or sometimes they call it Vader syndrome, vertebral anomalies, anal atresia, So like imperforate anus. Cardiac defects, these kids all have to have an echo. TE fistula, of course. Renal defects, and limb abnormalities like a radial, missing a radial bone or having abnormal radial ulnar anatomy. So before you do this surgery, you have to know that the aortic arch is on the left side. If it's on the right side, it's going to be more complicated. You can still do it through the right side, but you might consider doing it through the other side. You avoid positive pressure ventilation. They actually breathe spontaneously until you ligate the fistula. Once you ligate the fistula, they then can breathe for them. If the baby crashes in the NICU before you can get to the OR, you have to do a emergent thoracotomy and a gastrostomy because you don't have time to repair it. If they crash or they're super sick and you have to do something, or you're in there and there's some catastrophe, just ligate the fistula is a main thing, and then consider doing a gastrostomy. But if it's a true emergency, you just ligate the fistula and get out of there. So repairs via right thoracotomy. So then we went over that stuff. We don't have time for that. We're right at the time. Is that right? Or
You got 4 more minutes?
okay, we'll keep going. Okay, so quickly, mesenteric cyst, duplication cyst. So there's 2 types. Basically, it's either cystic or it's tubular. They all have intestinal epithelium. So if you do, when it comes back on path, that'll be the thing that they'll tell you, and that's how you know that that's what it is, because they have intestinal epithelium as opposed to some other type of simple cyst or other developmental cyst. You find these along the mesenteric border, and one of the important things is the blood supply is shared with normal bowel, which limits what you can do to it. So you have the cystic and the tubular. So a cystic one, these are the ones that we tend to see, and basically on the mesenteric side, you have an extra wall here, and it fills with mucus or secretions, and then basically you end up having to resect these because you can't. Sometimes you can just cut this off and then strip the mucosa out if it's important not to lose that piece. But what happens is the blood supply is all over it, so it's hard to do that. Now, when you have something like this, which is crazy, and you have a long duplication that's tubular, you have to get creative and figure out how you don't want to lose the entire colon. So you may go down here and make an opening to where it can drain out. These, unfortunately, we don't see these very commonly. So the cyst you'll see in the thorax and the rectum, you may find them incidentally because they may not cause symptoms, unlike the other ones. They're usually not communicating with normal lumen of bowel. If there's a gastric component, they may have ulceration and bleeding, like a Meckel's. Other symptoms, they may cause obstruction into intussusception because they can act as a lead point. The bowel can torse around it or volvulize around it. They can get infection, and there's been note of malignant generation in these. They all get resected because they're going to eventually cause problems, and they have a malignant potential. Esophageal and rectal, from what I understand, is a simple excision. Small intestine, if you can, resect it and anastomose it without losing too much bowel. That's the thing to do. But if it's in a bad place, or let's say it's in the duodenum up against the pancreas, or something where you're worried that you're going to, up near the great vessels, something you're going to cause trouble, you can treat it like a pseudocyst, although that's not something I've heard or dealt with. The tubular ones, more common in the ileum and the colon. They can occur anywhere, though. They're fortunately less common. They share a blood supply, the native bowel, and they commonly have an entrance into the bowel at some point. So you kind of have to figure that out when you go to fix them. They can be very long. They're more likely to be associated with other abnormalities, and you have to have kind of a customized, individualist, Ben Pierce sports car kind of approach, and commonly symptomatic. I don't know why anybody would do that, but I guess if you can afford that car and you can do that, that's your way of saying, I can do that and I can afford this car. So, all right, so next time we'll get into a different lecture, okay? All right. Any questions about that?